Hello and welcome to the Initiative webinar town hall event titled Navigating Patient-Centered Care, Ethical Disputes at the End of Life. My name is Sarah Kiskadden-Bechtel and I'm the Program Director for the Completed Life Initiative. The Completed Life Initiative was founded in 2019, created in an effort to promote self-determination and dignity at the end of life. The notion of what it means to live life until its completion, hence completed life, arose from our founders' desire to empower individuals to have full control over their end-of-life experience. Tonight's event features our panelists, Dr. Timothy Quill and Dr. Tia Powell, and our moderator, Dr. Virginia Brown. Tonight's event will look at different clinical cases that touch upon what a better standard for death might look like and how to balance the curative effects of medicine with the possibility of extending life beyond its natural conclusion with added suffering. What should be the default for patient-centered care in our modern institutions? How do we prevent unnecessary suffering? A bit about our moderator, Dr. Virginia Brown. She is an assistant professor at Dell Medical School and Department of Population Health at UT Austin. She earned her master's degree in philosophy with a concentration in ethics and public policy, and her doctorate in sociology with concentrations in race, class, gender, and medical sociology. Her areas of interest include the structural determinants of health, conditions in which people are born, grow, live, work, and age, and their influence on health and healthcare outcomes. As a researcher in population health, she looks to combine her work as a clinical ethicist and medical sociologist to expand not only researchers' understanding of research ethics, but also to enhance the way the ethical review of research extends protections from the individual to the collective. So without further ado, I will turn over to Dr. Virginia Brown to lead us in tonight's webinar event. Virginia? Virginia, you're muted. One moment.
You know, why can't I remember to do these simple things?
We can hear you loud and clear.
Can you hear me now?
Yes.
Okay, I don't know why. Let's try this again. Welcome and thank you. It's an absolute delight to be with you here this evening, coming from Austin, Texas, where it's probably like a balmy, 54 degrees or something, not to rub it in or anything. I want to introduce you to our presenters today. We have the privilege of bringing you Dr. Tia Powell and Dr. Timothy Quill, who will be in discussion with each other, with a little moderation from me, and so a lot of communication from you. So let's get started. I'd like to ask Dr. Powell, Dr. Tia Powell, to introduce herself, followed by Dr. Quill, and then I'll come back and introduce a couple ideas and we'll get started. Thank you. Tia?
Hi, thank you. Good evening, everybody. I'm the Shoshana Trachtenberg-Frackman. I hold the chair in biomedical ethics. And can I just say, I really have trouble saying that title, and I've heard so many people stumble over it and introducing me. So you made a very wise choice in having me say it myself for today. I am a physician, a psychiatrist by training, and I run a Center for Bioethics at Albert Einstein College of Medicine and Montefiore Health System in the Bronx. This evening, just to keep up with our weather theme, I am actually in the Hudson River Valley, and it will go down to 0 tonight. Ooh. So it's not balmy. So that's me.
Dr. Timothy Quill, a little bit about you.
Am I unmuted?
Yes.
Okay. So I'm, my name is Tim Quill, and I'm a recently retired professor of medicine, psychiatry, and medical humanities at the University of Rochester, where I have directed a palliative care program there for probably the past 25 years. I have done primary care and palliative care, so I have had a lot of care for people throughout the trajectory of their lives, and that's one of the parts of palliative care that I really love and enjoy, is kind of seeing the twists and turns of life and trying to make the most of things as disease and other factors start to intercede.
Wonderful, thank you. I'd ask our audience, we really look forward to your participation and your engagement in this conversation. We'll be moderating and looking at the Q&A and chat the entire time. Please put your questions in there at any time. I'm going to put these two scholars and clinicians in conversation with each other. I'm going to do my best to unpack any acronyms or things. Really looking for you guys to ask questions that we will pepper them with throughout. And at the end, we have about an hour for this conversation to unfold, and about another half hour to get really into an open Q&A. So not just Q&A about what we're going to be talking about, but more broadly towards the end. So Tim, would you first give our audience a little introduction into this concept of this thing called ethics consultation? You know, what is it? Why is it? How have you used it? And, you know, kind of walk us through what it might look like in this context of navigating difficult conversations towards a good end of life, or hopefully a good one.
So I think probably the best way to get into this topic would be to walk through a case. I mean, I do think there is in my mind, there's a lot of overlap between palliative care and ethics. So we are seeing all kinds of difficult problems that patients and families are experiencing as they get really sick. And many of those problems have ethical dimensions to them. And if they're on the easy side, if there are such things as easy ethical problems, we'll wander our way through them as best we can. I think that's part of medical practice. But when we start to get into more thorny areas where the path is a little bit less clear, or where we're getting to the edges of standard practice, I think that's when we are often working together with our ethics colleagues. And again, I'll be interested to hear where the discussion goes around that. So the way I think I'm going to get us started is with a case. And of course, I won't pick an easy case, because why pick an easy case, right? But it's a pretty standard case. And it's one that actually, in terms of the countertransference, which is the feelings that we have about what's going on with patients based on our own personal experience and our own, views and values. This one was lively for me from a countertransference point of view. So it was the patient was a elderly woman with mild dementia. She was a mom of a colleague of mine, and I was asked to give a palliative care consultation, which is not uncommon at all. Trying to make sure that she's getting the best out of her care. Make sure we looked at all the possible ways to help her feel better. Hear what she has to say, and of course, she was wondering about how much of dementia she was willing to put up with. That was what her question was, and she also wanted to know, what are my options if I get really tired of this, or if it really gets hard? And by the way, I don't want to go to advanced dementia. That's going to be more than what I want to do. And of course, in the countertransference world, my own feelings about this, I can identify completely with that feeling. I know that if I was faced with that myself, I would be definitely asking those same questions. So I had to some degree sit on those things a little bit, because it is a rich area for me personally, and it's not about me. It's about the patient, right? So I did what I usually do. I heard her story of her illness and went through what she was worried about, and did some evaluation about her dementia, and were there past, even though she had seen a neurologist, in fact, she had seen several neurologists and a dementia neurologist and a dementia psychiatrist, just to make sure all the T's were crossed and the I's were dotted. And was she clinically depressed? Might that be clouding what's going on with her? And, might she have some other medical things that are clouding her judgment? So I said, I said, well, first let's go through this evaluation. I said, oh, and then we'll talk more about this. And it sounds like it's not the time right now to really be calling it quits. And she also felt that way, but she was very fearful about waiting too long. Now, again, I had her also see, because again, in dementia and depression, that overlap can be very tricky. And so I had her see one of our most experienced geriatric psychiatrists. And that consultation didn't prove to say that she was depressed, didn't think that an antidepressant is going to really change what her views and values are in this circumstance. But it made me feel better anyway. So then I decided, well, she persisted in this question, what are my options? And I was, she lives in New York, I live in New York. So, and even if we lived in Oregon, assisted dying is not going to be an option for her because she's not terminally ill enough, right? Her prognosis is way too uncertain. So, but I am aware of stopping eating and drinking as an option. In point of fact, I've written papers on this subject. That's probably why she was seeing me, in point of fact. The question is, should I talk to her about this? Can I let her know about this option? And I thought before we get too far into this subject, I should probably get an ethics consult just to be sure that I'm not all out there on a limb by myself. And so I decided to have an ethics consult, and so we'll see I'll get one right now to see what I should do.
So kind of walk us through, for our audience who may have not had any experience with getting it, like, can only doctors call it, or can family members? Like, how do you get one? Where do you call?
It's like Ghostbusters, Well, I'll go ahead. I think I'll let Tia answer that, and if her answer is different from mine, I'll give you my answer.
Even better. So this is a little bit atypical for an ethics consult in that they need not be, but most ethics consults that occur are usually for somebody who's hospitalized. The typical case is someone who's very ill and may or may not have decision-making capacity. So if they say no to a treatment, but it's a really important treatment, it might save their life, it makes people very appropriately concerned about, I don't want to override the patient's autonomy, but if I don't do the surgery, they may die, and I know I could fix it. So that's a more typical ethics consultation where there's an end-of-life choice that's right now or very soon, and there may be a disagreement among various key stakeholders, the clinicians on the one hand, maybe the patient, maybe the family. So there's usually some sort of conflict mediation going on in a typical ethics consult. But the kind that Tim Quill is talking about now is not unheard of, where a physician might think, I'm not sure I know the right choices to present here for someone's care. I'm not sure if I'm pushing an agenda that's mine, as he has suggested, and he wants to be clear on that. So it's not unheard of for a clinician to say, even though there's no conflict right now, help me walk through what would be both clinically and ethically viable options for this person. So that's not an unreasonable thing. Virginia has also, in her way of asking the question, reminded me to say that properly done ethics consultation should not be only the province of clinicians, and certainly not only of physicians. So we welcome calls from nurses, from trainees of all types. They are often hesitant to call. In some places, they claim that they can make an ethics consultation anonymous. We don't make that claim because there's a limited number of people who would be concerned about a particular case, and a reasonably intelligent person can probably deduce who's concerned and made the call. So we will talk very carefully with somebody who's worried about, who's maybe a trainee or feels that they're not at the top of the hierarchy and they may face pressure for having requested a consultation. So that's a whole nother, piece of the pie. But here, this is very easy. This is Dr. Quill's patient, and he's thinking about what can I do? So I would do similarly to what he did with his patient. I would listen to his concerns, think about that with him. He has already been able to advise her. You can't request physician aid in dying with dementia. The way all states in the US have essentially the same model law, who have passed physician-assisted physician aid in dying. And it requires two pieces. One, that your prognosis has to be less than 6 months, so you're dying pretty soon, we think. And two, that you have to have full capacity. So you can't really ever have both those things and have dementia. If you're gonna die of dementia in a few months, it's essentially by definition impossible that you would really have full decision-making capacity. You might have dementia and be dying of something else, so that's a separate issue. But we've written the law to box out people with dementia. So that's never available to a New Yorker. But even, that's what Dr. Quill meant when he said, even if we were in Oregon, this would not really be an option for her. So what about other options? What about voluntarily stopping eating and drinking? And even before that, there's the easy plan of make sure you have your advanced directives in place. So I would look at both of those. I think that for everyone who feels that they would not necessarily want aggressive curative measures based on where they are now or where they feel the fear they'll get, it's very important to record that. Give your family a really clear roadmap. So if you're of an age, if you have a number of different illnesses, if you feel that it's likely that you're heading toward a time where you don't want aggressive curative measures, it's fine for you to say, I'm kind of done with colonoscopy. I'm kind of done with mammography. I don't want that stuff anymore. Don't look for trouble. Keep me comfortable. So that's perfectly reasonable and completely legal everywhere, and might be very difficult for your family if you haven't told them that. So that's the easy part. But I would work with somebody to say, think about stuff where you, if comfort is what you're into, let's make sure everybody knows that and knows what it means to you. But so then the trickier part. So talk to me, Tim, about what you think about voluntarily stopping eating and drinking. What does it look like? Have you offered that to patients before? You haven't heard about it? I mean, what's been your experience with that?
Well, am I muted?
No, you're fine. You're
okay,
fine.
good. So we did fill out a MOLST form, by the way, and she did have MOLST. Thank you. Medical orders for life-sustaining therapy. Again, there are some nuances within this. Clearly, she would not want to have resuscitation, shocking of her heart, a breathing tube, those kinds of things. But her quality of life was still okay. So would she want to still have some easily fixed things fixed? Now, the reason to do that would be she's still got a pretty good quality of life. The risky part about doing that is she may go through an illness and come out of it without capacity. Then all of a sudden, this option disappears. So there are some, I think, tougher nuances of that conversation that we talked some about. And her family was medically savvy. So again, I think if she had a major medical event, I think we agreed that we would just do purely comfort care. And if she had easy to fix things that were likely to get better, we're still going to fix for a while. So that's sort of where we went. In terms of whether I could live with her stopping eating and drinking, definitely. I'll just say this is me talking. And if someone in my family wanted to do that and were in this circumstances, I would be very supportive of them doing that. So again, I'm not opposed to it, but there are people who are opposed to this. So if I were a clinician in New York or wherever, and I was opposed to stopping eating and drinking, because of course it is intentionally hastening death, right? That's what it is. Then I'd have to decide, well, can I tell people about this? If somebody is going to choose it, can I take care of them, or do I need to find another doctor? And all those are things to sort through, again, either on your own or with a trusted ethics colleague or with a trusted colleague of some kind.
Tim, let me ask you a quick question to unpack in that when we talk about myself as a patient, let's say, and I'm saying, I want to stop eating and drinking. There's also a part of that at the end of life, it's a natural response in the body. So there's sort of two competing ideas. The one that I decide that I want to do this, but then there's this other part about the body. Can you talk to us just a little bit about why that actually does happen, and eating and drinking is no longer, they say, mom's not eating anymore, make her eat. Why that could be a bad idea versus the deliberate decision.
So there is, in very advanced disease toward the very end of life, it's a natural thing for appetite to disappear, to not drink very much and not be able to swallow very much. And that's a normal part of the last phase of dying. And sometimes we do have to spend a lot of energy teaching families about this and encouraging them not to push food and fluids on people, that it's a natural part of the dying process, and it would be inhumane to force things on somebody. And again, you sometimes have the question of a feeding tube can come up in that circumstance. And again, it's not certainly would not be a natural part of the dying process, although there are people for whom that would be the right thing to do. But clearly not this patient. That would not be the right thing to do for her. So we're trying to help them understand now, but this is different because this actually takes a significant amount of willpower. So if you go on some of you may have been on a fast, and you get ketotic pretty quickly on a fast, your breath smells fruity and you lose your appetite. So not eating is actually relatively easy to do, but not drinking is not easy to do because you get thirsty and you get really thirsty. And as you get closer to death, also, you may lose capacity because your electrolytes go out of whack and your kidney function goes out of whack. So you may become a little delirious. And when you're delirious and you're really thirsty, you might want to have something to drink. So again, you have to talk this through with people who are trying to do this and say, what are we going to do if that happens? And, I'm glad to encourage you to not eat, not drink if that happens. But if you're really saying, I got to have something, I'm probably going to give you something because it's too hard and it just doesn't seem right, because you might change your mind, right? It's possible. And there have been cases of stopping eating and drinking where people they've tried it for a while, it was too hard, they started drinking again, they started again, and it required a couple of tries to do it because it is not an easy process, the not drinking.
So Tia, when you think about, I'm going to put you in the role of the consultant, being that trusted ethics consult, to Tim, what other questions would you ask him as the clinician trying to respond to his patient about how to advise and, the risks and benefits and alternatives in a situation that he's described here?
I think, it's really, this is such a high laden kind of question. It's a really tough issue. This is a very challenging, maybe frightening decision that the patient would be grappling with. So I think I would want to acknowledge that, like, this will be a big deal for her. If she's not naming it, she may not know about it. So Tim may need to really talk to her about it in the way that he just spoke to us now, which makes it clear that it is a thing that's legal, that one can do. It's not an easy thing. It's not a snapping your fingers and I don't have to worry about this anymore. It's actually quite challenging. So I think that'll be, among those things that we think of as difficult conversations. That'll be a thing really to talk about.
Well, how did this case come out? What were your next steps? Oh, Tim, you're on mute. Now you're back. Yeah, there you go.
Okay. I put a question mark on whether it's legal. It's probably not illegal, but there aren't laws to allow this. So again, one of the good reasons to get an ethics consult is not that they can say it, that they cannot make up that there's a law to cover this, but it says that you've looked at all the avenues. You've looked at the morality of this in some sense and looked carefully at it, and that's helpful down the road if you got to be a test case or something like that.
Right.
So what happened with this was we actually procrastinated for about 3 months. So, knowing this is a really important point. Sometimes knowing that there could be an escape allows people to live longer than if they didn't know there could be an escape, right? At least that's been my experience.
Mhm.
So she felt, but the challenge was not to wait too long, because if she waits too long, she loses capacity. So she waited about 3 months. We met about once a month, and had conversations about her life and where things were and what she was thinking. And basically at the end of 3 months, she says, "I'm ready now." So we got hospice involved at that time, because of course she didn't qualify for hospice prior to that time, because her prognosis wasn't highly likely to die in the next 6 months, or more likely than not to die in the next 6 months. But hospice did get involved, and that was another area of support for her and her family as they did this. And in point of fact, it went very smoothly. She had a final dinner before she started. They had a celebration as a family, and then she went on a fast. She was from a religious tradition that has fasts, so it was fasting was not unfamiliar to her. And actually the process went very smoothly, and she died very peacefully. And people felt very good about how it went down, as did I.
So she really took hold of how she wanted to experience this last part of her life. I want to go back to something that you had said earlier in your discussion of this. You talked about the fear and the fearfulness. I've often heard that fear is nothing more than false evidence appearing real. So when we think about fear, and you talked about distinguishing between this fear and was this depression, can you help us kind of unpack what we might say to a family member who would come to us and say, I've really given this a lot of thought. I've got this diagnosis, I've got dementia. I don't want to be a burden, and, I don't want to live like this, And so if my mother says that to me, or my aunt, we're inclined to go, but of course you can live this. It'll be okay. I'm here. But they're really passionate. How do we, on the receiving end of that information, you've talked about being a clinician. Let's talk about being the receiving end as a clinician, and Tia, in your real experience with working with your mother, how does that look similar or different?
So there are so many issues to build on from what you were just saying, Virginia. I think dementia is very frightening. In various huge, national surveys, it is the disease that Americans fear most, more than AIDS, more than cancer. And I think there are a number of reasons for that. One is that I think our notion about dementia is that it robs us not just of memory, but of our identity. And that's very complicated for me. It is certainly a bad illness. It's a fatal illness, and it's a fatal illness that takes its sweet time ending things. So it's a illness that goes on for a really long while, which is not necessarily a good feature in a fatal illness, especially if you're not comfortable, if you're suffering. But I also think there is an extraordinary amount of stigma around dementia. So I hear a lot of people saying, it's just like you lose your dignity, you become incontinent. And that I find very troubling, actually, because there are a lot of people in the United States who are incontinent. A lot. There are a lot of women who, because of childbirth, because of bladder cancer, all kinds of stuff are incontinent. There are a lot of men from prostate cancer, from bladder cancer, from trauma. We have young soldiers, veterans of our wars, who are incontinent. I don't think that they should all be considering voluntary stopping eating and drinking. I don't think that something that is inconvenient, certainly embarrassing, should be a reason for us to think of that person as lacking in dignity. And so I am sometimes troubled by the conversation around dementia. I don't diminish what a bad disease it is. It is something both my grandmother and my mother had. And as a physician, I have seen it up close. And I understand that there are really powerful negatives, but we also create additional ones through essentially bias and thinking that to be less smart than we used to be is a terrible indignity. I think that's a little discriminatory. I don't think we should feel that a life, even our own life, less smart than we used to be, is a life that's not worth living.
Mm-hmm.
So I don't think that's what Tim's patient is saying, but I'm now putting out, sort of the fuller sense of my thinking about dementia. So it sounds like this was the right choice for this person, but I think it's also okay to talk to people about, what are you afraid of with dementia? Is it false evidence?
Mm-hmm.
I mean, being bedbound, being at the very final stage of dementia, that for sure is a really distressing state. You might be in pain and not be able to tell us. That's terrible. So there's a lot not to like there. But I think there are a lot of people who place an inordinate burden on even the intermediate phases of dementia. And we actually, because of bias, make dementia much worse than it needs to be for a lot of people in our community. So many people with early diagnoses of dementia described friends falling away. They and this woman and her husband had dinner every Saturday night for, once a month for years on end. And as soon as one of them had a diagnosis, that was done. It was too uncomfortable. So
uncomfortable for those of us witnessing the reality of our friends. There before the grace of God go I.
It's scary for us. It's scary for the people who don't have dementia.
Yeah.
So that's not really something to be proud of, for any of us, and I'm not saying I don't fall in that category too. It is tricky. You have to be much more patient with a family member or a friend who has cognitive disability, who has dementia. And it is hard. And it does make us fearful for our own disability and vulnerability. So I'm asking more. I think we need to keep a broader range of issues in our mind. When someone says, I'm afraid of dementia, it's fine to say, let me tell you about all the options. But first, what is it that you're afraid of? Maybe we could work on that in a variety of ways. And if it's something like incontinence, actually, we need better research on that. We need better devices and treatments. It shouldn't be, it's a mechanical problem. It's not a moral failing. So I think there are a number of ways that we can talk to people about what's the problem? What is it that you're worried about? That said, it's horribly expensive if you really need care 24/7. I think a lot of people feel like it's not going to make me happy, and I don't want to bankrupt my family. I'd rather leave that money, if I have any, to my kids. I don't want to be, so I think there's a very rich set of conversations that we might have that we often don't have about dementia.
So let's take that idea of these rich conversations and go back to something that Tim mentioned early on in this description, was this advanced care plan, this advanced directive. How do we take these conversations, right? Answer these fears, and then begin to memorialize them in this document? Can we take a little time and think about what that might look like, from the family setting, and then in translating that into the clinic, and most importantly, the retrieval of that document, when we need it.
Right.
I want to make, before we go there, I want to make a couple more points about things that Tia said, because I think these are really important points, and that is that the biggest danger that you have when people, like when this patient started talking about, I don't think I want to live like this, is that we bring our agenda and say, I wouldn't want to either. Let's go talk to the Hemlock Society, or, well, let's get all these consultations, and, it's not that bad. We have so many things we can fix, so many things we can do. And both of those responses are wrong. They might be a piece of the smaller piece of a puzzle, but the key is to, tell me more about that. Tell me the hardest part. Tell me more. So you really get a story for who this person is, what's important to them, where they still get quality of life, what they're afraid of, where they're not getting quality of life. And so once that picture is filled out, you're in a much better position to figure out what the options are, and as opposed to fixing or just saying, well, yeah, that I want that too. So again, to me, that's a really key piece of the puzzle. And I'm not saying that Tia is going to agree with me. I know.
I do. Yeah.
it's that conversation. I know, having done some of the clinical ethics work, the one key thing, we always hear a narrative. We always hear, how do you know this about the person that we're looking at? And we hear a story, and it's not a made up story. It has context and it has shape, and it's how we get to know this person who can no longer speak for us and tell us what they would want, in this moment. And I think taking that and trying to memorialize it into something that speaks for you when you can't, that gives your children or your spouse or your partner the strength to say, this is what they said, and I'm feeling really bad. Can we talk a little bit about how memorializing these thoughts and these wishes and preferences and your own personal experience with walking ththrough this?
Well, I'm glad to tell you what's in my advance directive, because it's probably a little radical. But basically, if I can't speak for myself anymore, if I lose the capacity to speak for myself, I want morphine for everything. Bad day morphine, cloudy day morphine, morphine, and I want 0, 0, 0 life prolonging anything. Everything is total comfort. And everybody who knows me knows that's what I want. And knows that I will haunt them if they don't do that. So that's what an advance directive is. It's and you may be very different than that. The more you can figure out what you would want, if you can't speak for yourself anymore, and you're not going to regain that, because that's really what an advance directive is. It's not for a temporary loss of capacity. It's really for a lasting loss of capacity. Yeah. And thinking that through is not that easy to do, and then talking to everybody who cares about you, because of course they're going to be the decision makers for you. Even if you don't do an advance directive, they're still going to be the decision makers for you, unless you don't have anybody. And then you really better be clear.
Yeah.
because the default is to do basically anything that might prolong life. That's the default. Which is, and that's a problem in itself, that's our default. You didn't say anything, more treatment.
Yeah, and I'll add just a little Texas wrinkle out here when we think about, end of life and who gets to speak for us when we don't have these advanced documents. If there are multiple children and there are a range of opinions, we're looking for a majority of them to come to agreement. So the idea of having to document conversation, and then the documentation of this so that we don't have disagreements or bad feelings, and that we can say, well, at least we're doing what mom or dad or auntie once said, abuela said this is what she wants. What would you say at this juncture of our conversation, Tia? Where would you pick up and guide us?
I'll take the conversation to a slightly different spot. I'll tell you about advanced directives in my family and my mother. My mother's mother had dementia and at some point got a pacemaker put in. And she ended up living all the way to the bitter end of dementia, but really speechless, bedbound, and just visibly kind of uncomfortable. It was terrible. And she had 6 children, and all of those, my mother and her 5 siblings all agreed, I don't want the pacemaker. That looks like a really bad idea. If there's an easier exit ramp for me when I am old and frail and clearly not enjoying life, I want the exit ramp. I don't want to keep ticking sort of on and on forever. So my mother did develop dementia, and she had said this, and I am also one of 6 children, and I was therefore the proxy because I was the doctor. At a certain point, she started developing, living then in a nursing home, these weird spells where she would become kind of unresponsive and nobody knew what it was. It was very confusing. Was it a seizure? Was it something else? And they kept shipping her down to the emergency room from her nursing home was attached to a hospital. And it turned out that she had a significant, she had heart block. Perfect. You know what the treatment for that is? A pacemaker. So the cardiologist was like jumping up and down, totally excited. This is great. I can fix this. So my 5 siblings and I had to have a conference call. And I said, you know, she told us she didn't want a pacemaker. And those of you who are in large families will know to a certainty that there is nothing on which 6 children can agree. Even do we all have noses on our face? There will always be a holdout. There will be somebody go, how do I know that's a nose? Maybe it's not a nose. So we were not in unison on that issue. And it was a really painful discussion with, you know, a lot of back and forth, a lot of gallows humor. One of my brothers said, I'm just telling you right now, you know, I don't want the pacemaker. There's like a little silence. And then literally 3 of us at the same time said, oh, you're totally getting a pacemaker. I'm going to come over there right now and give you a pacemaker. So a lot of anxiety, a lot of wrestling over this issue. We decided really against my wishes that, or against my better judgment, that my mother was saying, oh, whatever the doctor says is right, let's do that. Despite her having had a long time preference to not do this. And very reluctantly, I agreed that we could do it and that it would be on me to make sure we could stop the pacer when it was appropriate. That's a very difficult thing to do. It shouldn't be. The professional society that directs around pacemakers says it's like any other intervention. Consent is not permanent. You can stop a pacemaker, but it's actually in practice very difficult to get that done. But I felt that her quality of life at that time was actually pretty great. She wasn't uncomfortable or unhappy, and that it should fall on me to figure out how to stop the pacemaker. So we agreed to it, and she shows up in the little procedure room, or they come to take her to the procedure room, and the surgeon is there, and 2 of my siblings were there. I was actually not in the room because she was in DC and I was in New York. And they try to put her on the gurney, and she goes, what are you doing? And he goes, well, I've come to take you to put a pacemaker in. She goes, I don't want a pacemaker. You guys do too much stuff to old people. So she, in the event, actually was able to be herself and stop the ridiculous process of putting a pacemaker in that she didn't need. And I should say too, it still makes me angry to think about it. The reason one of my siblings go the pacemaker is that the cardiologist had said it will be a terrible death. It'll feel like she's drowning. It'll be really terrible. The actual death was such that she was far enough along with her cognitive impairment that she had no idea she had heart block. So she had no anticipatory anxiety, was not a thing she was concerned about. She didn't express when she had these episodes of heart block. She certainly didn't look like she was pain. She was totally unresponsive sitting there. And when she woke up, she had no memory of it. And ultimately, the periods got longer and longer. And she did die with that. So she died of that, but with dementia, I would say. And I think we all felt in the end that this was really consistent with what she wanted. So, you know, she was a good Catholic woman, and her understanding of that would not have permitted stopping eating and drinking, even if she had been in an earlier phase where that was possible. But she felt very comfortable saying no to something like a pacemaker, which I think is really important to note, because there are a lot of people who feel that their religious tradition would stand in the way of their declining something that is described to them as a life-saving treatment. But I think the right description, we all die. The pacemaker will not save your life when dementia comes to the end. So I think in her state of better health, she was really comfortable saying, I've seen what a pacemaker can do in dementia, and that's not for me.
Well, let me stop for just a moment. There's an interesting 2 questions that came up in the chat that actually sort of speak to this idea of how dementia can sometimes change a person's wishes and preferences and personality in a way, and like, who are we really advocating for? So let me just read them quickly to you both. Richard asked the question, how do we respond when a person embraces VSED and then with dementia progresses to becoming a new person? This person wants to eat and drink, not just from thirst and hunger, but a desire for community in a facility dining hall, taste, a feeling of being satiated, and then they derive comfort. We made a pledge to not feed the former person, but the new one sees this intake as comfort, hence comfort care. And adds, this is Dean, adds another dimension of this. How do we know what we want how do we know what we want as a person of the moment? Can we present as the person of a lifetime for another person? So, you know, who am I when I say yes back here? Who does disease has maybe become? And then thirdly, like, who am I? Because I'm in charge and I'm supposed to be the proxy, you know, decision maker for this new person. How do we think through that?
So we've segued to a different thing. I want Tim to help us understand the difference between voluntarily stopping eating and drinking and writing an advance directives that says, you stop my eating and drinking when I get to point X. So those are two very different things. And Tim, this is really your bailiwick. Can you help unpack those two for us?
Thank you.
So voluntarily stopping eating and drinking really requires somebody with the capacity to do that. And it is not easy to do. Capacity means the mental ability to really think that and sustain what it's going to take. And again, one of the good things of VSED, voluntary stopping eating and drinking as a option at the end of life, is it really does require some sustained thought. So it's not an impulsive reaction. It requires thinking it through and carrying it out. Now, again, as you get in a more advanced period of this 2-week process, 10 days to 2 weeks, you are going to lose capacity potentially toward the end, although not everybody does. And then it may be harder to sustain that desire not to eat and drink because you're really thirsty. So I think that's a harder situation. Now, stopping eating and drinking for an incapacitated patient, I think, is way harder. And I think my take on that is what's probably feasible in that setting is purely comfort-oriented feeding. So as much or as little as you seem to be showing an enjoyment with, it's not about adequate nutrition, it's not about adequate hydration. It's just the enjoyment. If you're not enjoying it, again, that really requires some unpacking with families because you have to really think it through. But it's a comfort. It's all about comfort, and there's wide agreement about that, and I think there should be wide agreement about that.
Yeah.
Voluntarily stopping eating and drinking, though, by advance directive is tough. Again, you can do the advance directive. If it's really what you want, I would encourage you to put it in your advance directive if that's how you feel about things, but it's still going to be really hard to carry out. But comfort feeding, minimal comfort feeding, the minimal amount that keeps you comfortable, I think, is easy and very widespread agreement about permissibility.
Yeah, I think that's a really important point. And the law here is very tricky. I'm not an attorney, but New York state laws make it quite difficult to withhold food and fluid from anybody who's saying, I would like that. So even if you have a surrogate that says, no, she wanted me to do this. So, if you are at home and your family knows that you want not to be fed when you get to a certain thing at a certain stage, and they're comfortable doing that, it's more possible. I think for some time it's going to remain very difficult to do that in an institutional setting. I think it's going to be very tough to have the aides and attendants in a nursing home refrain from giving food and fluid to somebody who is asking for it. And gosh, that's a hard thing to ask somebody to do. If you've seen the people who do that work, they are all love all the time. And it's not, for many of them, it's not consistent with what they understand their obligations to be.
But it could be done in a nursing home because the way it can be is family has to come in and be the caregivers.
Right.
So if the family's had the conversation, the family's feeling strongly that that's what the person would want, then they can come in and be the caregivers. And in point of fact, it's a very meaningful process. And you sort of take the paid caregivers out of the project, particularly if they're comfortable. Because again, you shouldn't have to do this if you're uncomfortable with it. That's just not fair to force somebody who has to do this for a living to do something they're going to be haunted by.
Yeah.
So our community of listeners has posted some more questions. One of which sort of leads to unboxing or unpacking something that was said earlier about how the laws have been written to box out dementia patients at the end of life in a very particular kind of way. Can we touch a little bit on that, and I think maybe link it back to some of these strategies or ways that we think about it?
I'll take a crack at it, and Tim, I know you will too. I mean, I think a lot of the aid in dying statutes really are conceptualized with cancer in mind, which is also true for hospice. So we think of hospice as sort of built in alignment with the model of cancer, that I've got all my marbles, but I know I've got this bad diagnosis, and so I am choosing to focus on comfort care towards the end. So I think that's why the hospice has traditionally had this sort of 6-month thing, sort of time limit to it. It's really thinking about the cancer model. And a lot of those laws, I think, I don't know that they were all saying, I want to prevent dementia patients from getting in the door here. I think they were basing it on a familiar model of cancer for the most part. That said, one of the major impediments to getting aid in dying laws passed is a fear that they will be used against people with disabilities.
Mm-hmm. Yes.
That this will be encouraging people whose lives other people don't value to hasten their demise. So I think that full capacity is in there because it's meant to protect people who are not able to make their own decisions, and people who arguably have not been fully valued as people over history by our society. So that's my general sense of why the laws are written that way. I don't know, Tim, do you disagree, or what do you think?
For aid in dying, my personal view is that full capacity is a requirement. It just, and partly my view is that because a lot of people think that, there's the contemplators. Many of you probably have thought about this as a possibility. There are the people who talk to their doctors about it. I would really like this in the future. People who are serious illness say, I want this in my future. And then there's the ones who get the medicine, and then there's the ones who carry it out. And the number of people goes down radically. So a lot of people want this option because it helps them feel secure that they're not going to be trapped. But when you actually get down to the time of doing it, life is pretty precious. And they may not want it, in point of fact. So that's a good reason to have it be that particular option to be limited to people with real-time capacity. And I think that's the way it should be. Now, again, when you start saying, well, what about terminal illness? How good are we at estimating terminal illness? What does it mean? 51% chance you're going to die in the next 6 months, which is sort of the hospice criteria, which is probably a reasonable place, but there's a big normal curve around that, right? So some people on hospice are going to live a couple of years, and some people are going to live a couple of days, and it's going to be everywhere in between. So again, you want to try to narrow down the prognosis, and for aid in dying, I think you have to be pretty clear about what the prognosis is. Otherwise, it's going to be available to a huge number of people, and I think that's going to be awfully hard to stay on top of, have a meaningful regulation, make sure that people are really sure, because it's a big deal.
Yeah.
Well, I want to bring you another question. Our audience is getting quite fired up and putting in a number of questions. So Brett has asked, a common argument against allowing any kind of aid in dying in dementia, whether it's physician-assisted suicide, PAS, or VSED, or something else, is that creating such a practice could make persons who are developing dementia, but who are not independently interested in aid in dying, feel like they are burdens, and so more likely to request aid in dying. Why do you, Doctors Powell and Quill, think about these concerns? Is there evidence that perceived burdensomeness might increase? Even if there was such evidence, would it be a definitive argument against such a practice? I guess that theme of, I don't want to be a burden, therefore I want to take these more drastic things before I become a burden. Like, I'm not a burden now, I never want to get there. So I'm going to take this drastic move to forestall it.
I think that's really interesting. I guess I look at it in a slightly different way. I think really I'm with Dr. Quill in thinking that full capacity is really important for physician aid in dying. So I do think people worry about whether or not they're going to be a burden. That's true for lots of people in lots of different ways. But for me, the need for capacity is paramount. I think this issue with burdensome, we have kind of not very good health policies in our country, frankly. And I can't fix that today, but I would love to see them fixed. I would love to see us have appropriate coverage for long-term care. So that people who live a long life don't have to worry about bankrupting their children and their grandchildren. I think that one of the huge failures of our lack of a real system for national health care is that we don't have any means, really, even for the middle class. I guess, Medicaid pays for nursing homes, but unless you spend down and get onto Medicaid, or you're very, very wealthy, really thinking about several years of needing to be in a nursing home is just horrifyingly expensive, incredibly so. So I do appreciate that people worry about that, and they're right to worry about it today. But I don't think the best solution is that we continue to think, well, definitely they should terminate their lives. I would like there to be other options. I think it would be great if that's what you want to do. I don't, that is going to be the right choice for some people. But really, are we okay with that being the best option? I don't think so. So I'd like to see what else we can do there. So I guess that's how I would respond. Tim, what's your take? Oh, you're on mute. You're still on mute. Yeah.
Am I unmuted?
And
Yes.
Yeah.
I'm in general agreement, but I do think it's a little bit more complicated in the sense that, and this is where maybe I don't know, maybe I'll go out on a ledge here that's too far, but people are living a lot longer now, right? Men and women, right? And the hope was that people would live healthy a lot longer. They would live sick a little shorter, and they would die peacefully. It's called the compression of morbidity theory. And it ain't the way it is.
True.
Okay. People are living healthy a little bit longer. People are living sick a lot longer. At the end of sick, they and their families are faced with very difficult things. And about half the time, at least, patients don't have capacity at the very end. So they're not even making their own decisions. I mean, this is a public health huge thing. And if we are going to say we're going to treat flat out all these things, we're going to have to really radically expand our nursing home. I mean, the population, this is big, and I don't have an answer for this, but I'm saying that this is a for real problem, and it's one that we are not very forthright, in my opinion, about really facing up to. Because there's no easy answer to this. The ideal answer in an unlimited resource world is to say, let's develop high-class nursing facilities for all the folks. And in my opinion, when you lose capacity, let's set the standard is comfort-oriented approach. Now that would be a big step in the right direction. That's the standard. If you want more than that, different than that, you can have it, but you better be pretty darn clear that's what you want by your advanced directive. We are now in the opposite of that. Right. The standard is, if you lose capacity, is full out aggressive medical care, and it's only limited if you've been pretty darn clear that you want it limited. And that, to me, from a public policy point of view, makes no sense. Because I don't know if most people, but certainly many people, if they lose capacity at the very end, don't want to have their lives prolonged with a lot of medical intervention.
And that's a whole lot of what's going on in this chat right now is asking the same question in different ways about where is my when? If I have my capacity, that seems to be the key theme that both of you are saying. when I'm capacitated, I need to be talking to everybody all the time, myself mostly, to get clear about what's important. And if what's important is I don't want to be this burden, that I don't want to put this on my family, bankrupt them, and so forth and so on. What ought we say to people is one of the questions. What ought we say to people who do not want to be a burden to their families? Despite all the constraints that you've outlined, the reality is this is where we are right now. And you know, I've said this to my children. You know, my father just passed away last month, vascular dementia. My stepfather in May. My grandmother many years ago. The list goes on. So I have said to my children, let me be very clear. Okay, let me be very clear, and we will tape this and you will put it in the vault and bring it out and show it to me. You know, that sounds a bit dramatic, but what do you say to us right now when we are grappling as individuals and not grappling with our parents? We're trying to think through this right here, right now. What can we do to not be that burden or make it less burdensome?
I think there's some things that where we really need to change our culture that are within our grasp. And basically, a version of what's sometimes called slow medicine is available to us. So in other high-income developed nations in Scandinavia, it's very unusual to admit a person in their 90s to the ICU. The intensive care unit is not really for that person. What are we going to fix that will really restore them? So we have a notion that everything that's broken must be fixed. And it's not clear at all to me that that's true as we have multiple comorbidities and reach the end of a natural lifespan. I don't want that kind of care for me. Even if I am cognitively intact, I'm not sure that I want to be hospitalized for everything that comes up. Mm-hmm. And certainly if I have dementia, I know I don't want that. I don't want to go to a hospital unless you can't keep me comfortable, unless you need to do something to make me comfortable that you can't do wherever I am. Because just taking somebody to a hospital is unbelievably uncomfortable. Mm-hmm. I work in a big urban hospital. There are frail older people, and lots of different ones, just lying on a gurney. They're freezing cold. It takes hours to figure out what's going on, go up to the floor, can you treat their pneumonia? Maybe they'll just be there for a month and then die. But like, no part of that sounds appealing to me when I'm that age for my own self. So we can do that now by having family members educate themselves and push back when they say, oh, your mother's in the nursing home, she has pneumonia, but we can treat that. I think you'd be made today to feel like you were a horrible person.
Yes.
You said, why? Why would you treat that? What would be the benefit of treating that? Do you need to really take her to the hospital and give her IV antibiotics? Well, that sounds like the burden of that is much greater than the benefit. So you really don't have room to say that now. And I think we need to push back. A friend of mine was telling me her mother had advanced and had like a small bowel obstruction or something, and they wanted to operate. And they said now, because of her condition, we're going to have to leave the surgical wound open. So we're going to have to restrain her probably for 3 weeks. And the one is listening to the surgeon and going, listen carefully, no way in hell are you doing any of that to my mother? So, and he was incredibly distressed. So we need to change this culture. We don't have to do that. We don't have to think that's the only way to help somebody.
And can we change the culture? I mean, it's very hard as a moderator. Your goal is to not insert yourself into the conversation. But I must say, you were reading my mind. I got the call in the middle of the night, the literal middle of the night. Your dad, bowel obstruction, la, 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 la. And I'm like, you have got to be kidding. You're really calling me to make this recommendation? What year are you? And so it makes me think, your conversation makes me think of two things. Not only we as individuals pushing back on behalf of others, but also asking the clinical team to reassess how it represents risks, benefits, alternatives versus what are you doing? Trying to kill your father?
Right.
How, where does that come in? And I see all your questions. We'll get to them, but I think this is an important part of the conversation of consumers of healthcare and providers of care shifting in this conversation. Where are we with that? Oh, Tim, you've muted.
I think
You may just be hitting the keyboard by mistake. Sometimes a quick swipe on the keyboard will do it.
it's all good. Both of my kids, one of my kids works in an ED, one of them works in the ICU. And the number of people with advanced dementia who are showing up at both of those places is probably, I don't know, a lot, half.
Yeah.
And we just don't have really standards of care that make sense in those circumstances. Again, the minimal comfort feeding only should be the standard of care. Now, it doesn't mean people couldn't get other than that.
Right.
But the standard of care right now in our system is treat if it's treatable.
Right.
Long life if it's possible. And you have to actually be quite strong to stand up to that. Now, there are between clinicians huge differences. There are between institutions, between intensive care units, very different approaches to these things. And that should be way more studied than it is. And we should come to grips with this. That variation does not have to do with patient values.
Right.
That variation has to do with the values of the clinicians, mainly doctors, who are running those ICUs. And of course, if you haven't made a decision to stay out of the ICU, once you get in the ICU, that's what they're built for. And by the way, there's a lot of money that exchanges hands when we do all that stuff. It's the most expensive care. It's really well paid, whereas comfort care is not really well paid. So if you're an economic determinist, you're going to say that's going to drive a lot of us, and it does drive a lot of us in this country. And again, we need to have a conversation about that. It would really radically change how we could really rethink how we finance some of this stuff, particularly for advanced age and advanced disease.
Yeah. I think our training of physicians is physicians are made to feel bad if you die of what they can fix. That you die is immaterial, and obviously it will happen at some point. It's just really bad if you die of their thing. So this is a really bad business plan. We really have to get over that.
Absolutely.
Tim, you're muted again.
Oh, me?
No, Tim is. Tim was.
Oh.
It's a good business plan for making money in medicine. It's a bad business plan for quality of care, particularly at the end of life. It's a good business plan for care at different phases of life, when that aggressiveness really can pay off. But it's not for people who are at the very end of life. It's a really bad plan for them and for everybody. Yeah.
I want to pick back up on a theme that keeps recurring in the chat about voluntarily stopping eating and drinking, VSED. People wanted to go back to the patient that you talked about, Tim, you talked about she went for 3 months thinking, and then made this decision. There seems to be something different about being at home versus being in an institution when this is done. While it's not illegal, does age of patient and or disability like quadriplegia impact VSED as an option? One of the questions also adds to it, you said that her death was smooth and comfortable. What palliative measures can be used to ease this discomfort of thirst and dehydration? I know that's a number of things, but it all centers around that theme.
So the dry mouth is the really hard thing to palliate because you do get very dry. The hunger goes away very quickly. You get ketotic, as I mentioned before. So swish liquid saliva and then spit is the way to go. So you can keep your mouth moist, but try not to swallow very much liquid because the more liquid you swallow, the longer it takes. So you really are trying to not do that. The other challenge of VSED is that you tend to lose capacity toward the very end. Again, comfort-oriented care, we usually can take care of that. If people are uncomfortably delirious, we can provide them with gentle sedatives and those kinds of things. So I think it can be managed pretty well once it started. Making the decision to start is a hard decision, and figuring out the timing of it for a particular individual is tough. Not waiting too long, but not starting too early. So again, you're trying to preserve the quality of life, and yet you're trying not to take the risk of losing capacity to carry it out. Now, again, the backup plan, if somebody was wanting to do this and wasn't able to pull it off in time, or decided not to do it, would be purely comfort-oriented feeding, as we discussed earlier. So it's basically minimal comfort feeding. We know that she was talking about this for a long time, but now she was unable to carry it out. But let's do minimal comfort feeding only, and that is actually usually doesn't go on for a long time, and it's compatible with hospice.
And I would assume in that discussion, it's critically important to have the advanced care plan also documenting this, or with the medical team, like the construction of all of that.
Yeah, all the medical, the DNR, DNI, everything's comfort oriented, and then you need to have an advance. Now, again, if somebody didn't do an advance directive, and you talk to the family and there were conversations, I think you just document that those were the conversations. It really helps if you're really doing minimal comfort feeding only to have a unified family in this, because otherwise families get a little cranky.
And they also hear, as Tia's sibling did, that this is going to be horrible and horrific. And that fear and not having full information.
But comfort feeding only by and large gets around that. Anything that appears comfortable you give. It's not trying to maintain nutrition and hydration.
Tia?
I saw that there was a prompt from my friend and colleague David Hoffman about feeding tubes. So just quickly, for an unfortunate period in medicine, feeding tubes became the norm for people with advanced dementia. Swallowing difficulties are very common in people with advanced dementia. More than 90% have that. And for a while, that became the norm. Happily, that's no longer the case. So the American Geriatric Society and various other groups have said that the standard of care in advanced dementia is not to put in a feeding tube. So again, I think that's something where educated family members and clinicians need to push back. If somebody says, well, your mother can't eat anymore, she has to have a feeding tube. That's not the case. So you can, even though a person has some difficulty swallowing, you can move there to hand feeding done carefully, comfort oriented. And the norm now is not to go with feeding tubes. So I think we can actually do a lot of good. They're uncomfortable. If people don't like a feeding tube, they end up sometimes getting restrained, which is just a miserable experience for anybody. So that I think is a real gain. After 25 years of studying this problem and promoting it, I do think the tide is turning. There is more room to push back against feeding tubes and that sort of forced continuation of nutrition for people with advanced dementia.
So in keeping with that idea of pushing back and changing the conversation, there's a question from Donna who says, how do we redo palliative care into two categories, cognitive, cancer-like, versus dementia? How can we think about pushing back or changing in that space?
Well, I don't think the categories are separate. Dementia, to the extent that it affects people who are older, is often occurring in somebody who has multiple comorbidities. So they may also have congestive heart failure and rheumatism and all kinds of other things. But there are people who are really trying to focus on what good palliative care in dementia looks like. They didn't really know before. And one of the sad things about dementia is that it does become quite difficult to express yourself, or even maybe to locate where pain is. So we do think that there were probably people with advanced dementia who didn't get adequate pain control in the past, and that's inexcusable. There's absolutely no reason for that. So there are various groups now that are sort of working on what we could do. They see agitation. They try and figure out, is that a pain issue? Is it an anxiety issue? Is it, something bothering? So there are various steps that you can take. I don't mean to be demeaning, and sometimes people feel that way when you compare older people to much younger people, but it's not in some ways that different from the care of an infant who also can't express themselves. So when you have a baby who's clearly uncomfortable, you look at what's going on. Is this baby cold or hungry or wet? Is something poking them? And you go through the litany of different things, all the while actually offering human comfort. Just they're there, and patting on the back, and you're not alone, and we're here with you, and we're concerned about your crying. And sometimes that's all it takes. So going through, figuring out how to train people who are whether it's a family member or a paid caregiver, how do you deal with a person who can't tell you what the matter is, but who clearly appears to be suffering? How do you do that better? So that's something where I do think good work is beginning on that, and where I feel there's so much room for improvement.
This should, in my opinion, that would be considered a palliative care emergency. So again, and what you do when you have a palliative care emergency is somebody's nearing the end of life and they're suffering high, prognosis is low. Then basically we get geriatrics, we get palliative care, we get geriatric psychiatry, and we brainstorm together and say, look, we got to figure this out, because this is we try to imagine what it's going to be like to be at that bedside 24/7 and be in that body 24/7. And if they're in anguish, that is an emergency, and we have to view it that way. And sometimes the answer is going to be sedation. And that's okay, because you would never let somebody who is dying be in anguish, be in agony, if you could relieve it. Again, that may be the last resort or one of the last resorts, but it still is better than letting people be in anguish for long periods of time.
I agree.
Yeah.
Okay, so I think this next question, at least for me, is very complicated and difficult and fearful. How can you guarantee that your family member, the appointed person, must follow your advance directive? Paula says it happened to a dear friend, and I infer that it did not get followed. So we talked about the importance of this document, this narrative, this story, and then people just sort of like light a match to it. What do we do? What can we do?
Well, I'll tell you what I told my kids. I probably have already said this once. I said, I will come back and haunt you if you don't follow my advance directive, because and by the way, I also don't want you in my advance directive if you can't follow it, because it has nothing to do with you. It has to do with me. It's my values. It's my life, my death. And that conversation should be had. And we clinicians should be making sure that people understand what the job is. The job is not what you want for your loved one. It's what you think they would want under this circumstance. And that's a very different question. And I will tell you, in ethics and palliative care consultations where we've had families like slugging it out, I think we should do this, I think we should do that, and you say, well, we sit in an empty chair for mom. And what do you think mom would say, if she could speak? And they say, oh, she would be mortified by all this. She would hate it. Well, that, if I'm running the consultation, is the end of the conversation, because the job is to figure out what mom would want. And sometimes it's clear. Now, a lot of times it's not clear, because mom didn't like to talk about it, or the family didn't like to talk about it.
I do think it's very hard to be a proxy for someone, a surrogate decision maker. And in some ways, the people that we pick, the people who love us, are in some ways the worst possible person to make that decision, because you don't necessarily want to lose your mother right now. So, I think it puts that family member sometimes in a really painful decision, and people don't always, in duress, respond rationally. They know that's not what their loved one wanted, but they have a conflict of interest. So what Tim is saying is very important. You need to remind them, we're not asking you if you would like this person to go away. We're asking you to stand in for them and tell us what they told you, what they would want. And it's a very hard job. It takes a lot of courage to do as someone has asked you to do. So it's not an easy thing.
There's one other layer of complexity about this, which is sometimes people would, would say, if they could speak for themselves, I would definitely wouldn't want this, but I'll do it if it'll make her feel better about this, right? Because they're caregivers, right, for this proxy,
Right.
and that's just another twist on this whole conversation.
Yeah.
And by extension, I don't have to pick a family member. Could I pick somebody else that I know could do this and then provide comfort to my family? Are there other options? Who your surrogate is?
I don't know. I mean, I come back to family, and it's sort of like democracy. It's the worst of all possible governments, except for all others that have been tried. Your family members are the ones that are likely to be there. But it maybe you do have some choices. I know a number of people who have not chosen their spouse to be their decision maker because they just feel like either it'll be too hard or they just want them to be in charge of comforting and being with. And they want somebody else. They may want, a niece who's an attorney or a nephew who's a doctor. There may be somebody who's close, who cares about them, but is not as directly in the line of fire, won't be affected in the same way by those choices. So I do think it's an interesting question. We always think about it's the person closest to you, but I'm not sure that's the best choice always. But I use Tim's. I've definitely told my family I will haunt them.
Oh, yes.
Be down with that.
If you have chosen somebody else, though, it's really everybody's got to know that and got to know the why.
Yep.
So it's not a big surprise at the end because and if there's a good reason for it, then everybody's got to know that because you can't be having that conversation for the first time when you've lost capacity and you're in extremis, right? Which is the usual way that you're having that.
Well, I have a question here from Rebecca, and I'll read it to you. She asks, as an end-of-life doula, I'm working with an 83-year-old woman whose cardiologist just told her she was reasonably moderate. She has a reasonably moderate chance of having a major heart attack. We're doing her advanced directives. Her concern is having a major attack and not being able to return to her current life in her own home, independent, etc. And also being cognitively impaired, losing ability to do what gives her joy. But she is wary of a DNR, a do not resuscitate, and not having cardiopulmonary resuscitation, CPR. I do not want to choose death. I said, maybe it's not your choice. And then discussed what is a natural death, which was how her faith looks kindly on it. The question is still open. Do you guys have any thoughts? How do you manage that tension?
So that's actually really interesting. I think I would want to speak to this woman. I'm actually, from this little bit that we have, I'm not sure that she should have a DNR order now, but she needs to make very clear what she would want if, in fact, she gets to the stage where she is not going to recover, she's not going to be able to be independent, and it might be then that she does want a DNR order. So if she's worried about it now, I don't think there's any reason to tell her that she couldn't have attempts at treatment and of whatever kind. But she needs to make sure that she's put in a stop order for some point. Don't want everything. But there are a lot of people who feel uncomfortable saying, don't try and bring me back if you could. And, it's a very difficult decision. So I don't know, Tim, what do you think? I find it's a difficult question.
Yeah, I would be wary in her shoes. I'll put myself in her shoes. I have no desire for a gigantic medical adventure at this stage in my life, even though I may have one. And I'm not DNR, DNI, right? Because I could have, like her, I could have something that was really easy to fix. And I'm fixed. I still have a lot to live for. I'm old, but I'm not decrepit and stuff like that. And I would love to keep going if I can. Having said that, if I go through some of that stuff and losing capacity is a complete deal breaker for me. So if I'm losing, and this is just me, it may not be others, but losing capacity is a deal breaker. So at the moment that I lose capacity in any way that's highly likely to be irreversible, then I want comfort measures only. And everybody knows that about me. And I think that's what this person should think about. So, not ready to choose death, want to have easy things fixed. But if something really bad happens and, you get into a medical adventure and you're not going to get better, you want it stopped. And I think that's what most people would want as they get a little bit older, or maybe a lot older.
Yeah, no, I think that's very well said. That does seem to be what she's asking for. If you can fix me, please do. And then when it looks like you can't, then just keep me comfortable.
Right. Can you take us through some language? I was intrigued by your use of the word a stop order, okay, in saying, okay, try, but you really need to stop here. How might that conversation take place? With whom? Should we say it? How would we enter into it?
Well, to some degree, it's the advanced directive conversation because if it's not when you lose capacity, you can put your own stop order in, right? Because you have capacity. You can say it's too much. So you don't have to necessarily build that stop order in, although you could try to build it in. But losing capacity really changes the game. And if you have to think about what treatments would you want if you lost capacity and you're not likely to regain it. And again, I think that's where this person and people like me will put in pretty hard, if we can, put in pretty hard stop orders.
And that's really the medical orders for life-sustaining treatment is perfect for that. It really does ask sort of what would you, this happens, what would you want done? It's really designed, I think, to step in and do that for you.
Well, I just want to let our wonderful panelists know that we have 2 minutes left. Audience members, we have 2 minutes left before we wrap up. So yeah, I'm not seeing anything new pop up in the chat. Oh, something just came. So let me see. Just to confirm what Dr. Quill means by capacity, does he mean just making informed healthcare decision or also for physical?
No, I apologize. I'm using medical jargon here, which I shouldn't use, but capacity in the sense I was using it is the ability to make your own decisions, the ability to make your own medical decisions. So you don't have to have the capacity to balance your checkbook or, to do other cognitive things, but you have to be able to understand your medical situation and the options that you're faced with. And if you have that, then you have medical capacity. And if you don't have it, you don't have it. And then people have to figure out what would he or she want. That's the advanced directive.
Well, I want to take this time as sort of the moderator prerogative and ask both of you, if there was one thing that you could say to the audience members, each of you, if there was one thing you could say to our audience members to take away from today's discussion, what would that be? To go first?
Sure. That medical care should be about helping people and doing good. And it's not always. We sometimes or often, unfortunately, do things in medicine that do not obviously help our patients. And that, I think, is an enormous kind of unnoted ethical failure in our healthcare system. And I would love to see us as a community think about what we could do to take that on, to sort of rewrite the balance of when healthcare is really in the service of the patients. And then one other naughty thing that I wanted to say, I wanted to promote Dr. Quill's forthcoming book and my existing one. So I thought I would sneak that in under the wire.
Please.
Ah.
There it is.
There you are, Tia.
I forgot you were going to do that. Thank you.
So for everyone watching, Dr. Powell's book is Dementia Reimagined, Building a Life of Joy and Dignity from Beginning to End. And Dr. Quill's book is shortly forthcoming this year. It will be published by Oxford University Press, entitled Voluntarily Stopping Eating and Drinking, a Compassionate, Widely Available Option for Hastening Death. And both of these incredible books reference a lot of the themes that both Dr. Powell and Dr. Quill have explored with Dr. Brown today. So thank you, all three of you, so much. This has been a phenomenal presentation.
And I want to throw it back to Tim for just a quick second before we go, Sarah, just to give us that closing thought as well, the takeaway.
Please take it away.
My takeaway is tonight or this week or next week, sit down with the people you love and have this conversation about what kind of care you would want if you lose capacity, because it's one of the most important things you can do. Because you can make decisions while you still have capacity, but if you don't, they're going to be the ones making it, and they need to know what you would want. And it means you have to figure out what you would want. Not easy, but it's worth doing for sure.
Thank you.
Pleasure.
Thank you. And Dr. Brown, any last remarks?
Having lost my dad last month, I feel comforted by what was reinforced here, that it is the conversation, and it's literally putting the patient at the center, putting my dad at the center of it. What would he say? I had enough information from written stuff, but knowing what I know, I uplift what you both said. Write it down, have the conversation, normalize it, get rid of the stigma. None of us get out of here for free. It's gonna happen. Let's try and make it, as comfortable and normal as we can. Thank you for the privilege of working with both of you today and for the opportunity to moderate such a wonderful discussion.
Thank you.
Thanks,
you
everybody.
each. And I'd like to conclude with a short poem by Mary Oliver that I thought was really topical and relevant to what you've discussed here today. And it's called "I Worried." She says, "I worried a lot. Will the garden grow? Will the rivers flow in the right direction? Will the earth turn as it was taught? And if not, how shall I correct it? Was I right? Was I wrong? Will I be forgiven? Can I do better? Will I ever be able to sing? Even the sparrows can do it, and I am, well, hopeless. Is my eyesight fading, or am I just imagining it? Am I going to get rheumatism, lockjaw, dementia? Finally, I saw that worrying had come to nothing and gave it up, and took my old body and went out into the morning and sang." So thank you all so much to Dr. Quill, Dr. Powell, Dr. Brown for moderating such an incredible discussion. And to you, our Completed Life community audience, it's been a joy to have you here and an honor to sit with you this evening. I hope you learned a lot from the discussion tonight. I did, certainly. And I look forward to welcoming you back to future events with the Completed Life Initiative. So please feel free to sign up for our mailing list if you haven't done so already. Our website is www.completedlife.org. And we look forward to seeing you again soon. Thank you again to our panelists and our moderator. And I wish you a good evening or a good day wherever you are in the world. Be well.
Be well.
Thank you. Bye.
Thanks.